Good afternoon, everyone. I'm Nadia Stachowicz. Today we have with us Dr. Frans de Jongh from the University of Twente. We're going to be discussing with you today the management of PFT workflows and how you can, in your own lab, use these new 2022 ERS ATS standards by stepping through each of those decision trees and classification tables step by step. Dr. de Jongh is going to walk us through that. And with no further ado, I introduce to you Dr. Frans de Jongh.
Nadia, thanks. Yeah, I have the honor to do the first part of this webinar. And indeed, it's based on a huge document, which is quite new, helping us to understand how we can optimize the interpretation of lung function measurements. And as you can see, I'm now here at my own hospital in Enschede in the Netherlands. I have 3 places where I do work. Here in the hospital, having an adult pulmonary function lab, one of the biggest one of the Netherlands, but also 1 day a week, the neonatal intensive care at the University of Amsterdam, the academic medical center there, where I started myself in 1989 measuring lung function of premature neonates. So the very small ones, 600, 800 grams, and that's how I learned it. And only in 2000, I became also head of the adult pulmonary function lab. And last but not least, I work on the boundary of technology and medicine. You can see that my background, as in the bottom is stated, is engineering fluid dynamics. I have a technical background, so to start, my master was in techniques, but calculations of airflows around airplanes or in lungs or in hearts, it's all the same laws, or only the geometry is more difficult in the pulmonary system. My conflict of interests are none, but as people might know, I am already for a long time an officer in the European Respiratory Society, the ERS. Started there as Secretary of Assembly 9, which is lung function and pulmonary physiotherapy and the nurses, but my topic was, of course, lung function. The Dutch Pulmonary Society is the NVALT, the Dutch Respiratory Technician Society is the NVLA, and the Dutch Society of the Primary Care Doctors who are doing lung function. And in all those organizations, I am an officer. So I do learn and teach lung function from old to young, from primary care to the ERS itself. And I was invited via air to give you some more information about how we can do the interpretation of lung function nowadays. So this is the main goal and the main aim of this talk, interpretation by the new guidelines or technical standards. To help you, I will give you a small background about GLI, and I will guide you to some cases which are pretty normal. And in the last 20 minutes, 50 minutes, Nadia will show us some patient real-life examples and how you can, if you use Central Sheet, see what can all be done with Central Sheet. So why did we have a new document? Because this new document, it's of course in the slides, and it's quite an amount of paper. It's something like, if I exclude the references, it's 25 pages in a very small font, but it's a logical construct coming out of the 2005 series. In 2005, we had 5 series in consecutive ERG journals. The first one was lung function in general, how should I do it? Then one about spirometry, one about static lung volumes, so like the body box, one about CO diffusion, and the 5th one was interpretation. And this paper really is a replacement or an update of the 5th one. How should I do the interpretation if I have outcomes measured with all these technologies measured before? So as you can see on this slide, there are several reasons. Well, if I say 2023, it's nowadays 2005, who has a computer or a mobile phone which is 18 years old? No, nobody does. Devices do get updated. And 18 years is really a long time. And what we can see also, there was a high variability in how we should do the interpretation of data. And what also was quite some discussion in that time. The 2005 documents really tried already to help the clinician to make a kind of clinical diagnosis out of the interpretation of all the outcomes. This paper stated more, let's say, better. It is a consensus document and not based on the research how you should do the interpretation. That's up to the clinician, but we'll come to that later on. As you can see, the authors were really from all over the world, as people might know. Already for several decades, the ERS, European Respiratory Society, and the ATS, the American Thoracic Society, always want to make task force documents, consensus statements together and hope they can be applied worldwide. And they are also therefore made to be applied worldwide. And we want to have also therefore representatives in all these documents worldwide. And also the last thing is, if they are published, they're normally always open and free. So even if you're not a member of one of the societies, you can always find these kind of task force documents free on the internet. That's on purpose. What the new standards, what the document tries to do is indeed to classify what is within or outside the normal range, and what it is, I will come later on. And if it's something is outside the normal range, how do we classify it? What is mild, moderate, severe? Because later on we will see it will nowadays be based on Z-scores, which we certainly didn't use in 2005. But if you want to do the clinical interpretation, you can see you should combine all the outcomes, the spirometry, the static lung volume, CCO diffusion, whatever you do have, with clinical data, and then you can, as a clinician, see if you go to a diagnosis or a differential diagnosis and perhaps to therapy. So the bottom lines state the determination of diagnosis or management plan is beyond the scope of this new standard. It is a technical guidance how to do a physiological interpretation. So keep that in mind. Of course, we hope that it can be useful for your clinical interpretation, but it is not a clinical interpretation. And this is what I just showed in my hand, this document. This is the title, so then you are certain where we were talking about, and perhaps even some of you might have seen the ERS webinar a week ago, where Sanja and David and Martin and Igor also talked about this document. But we will try to do the applications and go more standard to all the decision trees. What are the main differences between this and the 2005 documents? On the left, you see a lot of text in the 2005. On the right, you see the 2021, well, it's end 2021, but published in 2022. So sometimes people do think, is it 2021 or 2022? But we refer normally as the 2022 because it was published in the ERJ in 2022. And if we zoom it out, what are the most striking differences? We can see what I already stated. It's based to classify physiology and not go directly to a clinical diagnosis. We have much more focus on a lower limit of normal, and see what you can do if your outcome is close to the lower limits normal, just above or just below. We recommend to use the GLI, the Global Lungs Initiative reference equations, because they are now also out for, they were already out for spirometry in 2012, but the static lung volumes came out 2 years ago, and the CO diffusion in 2017. So for all the outcomes, we do have GLI reference equations. And of course, there are complicating factors, and of course, there will always be a discussion about the influence of ethnicity on lung function. There is a new, just published paper in the Blue Journal, the ARG-CCM, going into discussion about that. clarification of your, that if you have to fill in what your gender is, that you use your biological gender, because otherwise you get an over or an underestimation of your outcomes. And in general, use your lower limit of normal, which is equal to the 5th percentile. And some values might also be too high, and then you use the upper limit of normal, the 95 percentile. And what we certainly do not recommend, use the fixed ratio, which people still might use as if the FEV1 over FVC is less than 0.7, then you are obstructive. No, this lower limit of normal is decreasing if you become older. So it's way better to use the lower limit of normal. And also don't think 80% of the predicted value is normal. Also, this is highly variable on age, dependent on age. So as stated, we have GLI outcomes for all the GLI papers for all the main outcomes. And the 5th and the 95 percentile are nowadays expressed in Z-scores. That's how many standard deviations you are away of the mean. And if it's less than 1.64 or higher than 1.64, you are so far away from the mean that we say it's only a 5% chance that by coincidence, statistical coincidence, it's abnormal. So there is a quite high chance that we have a value which is so far out of normal that there might be a disease. And this is what you can see as how you can do an interpretation from Z-scores. You can see the Gaussian distribution, which not always has to be Gaussian, but you can see that you have the boundaries, which is the 1.64 minus or plus. Some parameters can only be too low, some also can be too high. And then you have a clear range that if, for instance, in this example, you see the big black arrow over the FEV1 is in the dark gray area stating, okay, FEV1 is too low, it's more than 1.6, it's too low, so this might be a disease which has a low FEV1. FVC, the big black arrow is in the middle, okay, and FEV1 over FVC is again at the left side. You immediately can see therefore, okay, we have something which might have a normal FVC, so perhaps not a restriction, but FEV1 and FVC is too low and FEV1 is too low. It is could be an obstructive pattern. As stated, also the severity now is not based anymore on percentages, which formerly was based on percentages of predicted, as 80% being mostly normal, 70% mild, 60% well. And this is now based on Z-scores, and you can see it's on the red angle on top, but also in the bottom side, a bit enlarged, that we say something is mildly wrong, impaired, if Z-score is between minus 1.65 and 2.5, moderately impaired, it's 2.5 to 4.0, and severely impaired, if it's more than 4.1, lower than the mean. So more than 4 Z-scores, 4 standard deviations lower than what it should be. And why we use Z-scores? Well, perhaps people do know these kind of graphs, and I apologize, this is a Dutch version, so you don't, but the letters are small, so you cannot see the text at all. But what we do know is that if you start to grow as a child, you see that you have an upper and a lower limit of normal, a P5 and a P95, which really starts to become wider when you are aging up. And already for decades ago, everyone found it normal that your standard deviation depends on how tall or how old you were as a child. We already used these for decades. And nowadays, it's therefore very, I would say, obvious that we should also use these kind of graphs using Z-scores and upper and lower limit of normal for lung function. And that this is a way better way to do it than going to fixed values. So VIA already had a webinar about the GLI. So if you want to have more details, you see in the bottom line a link, which if you do the replay will be more clear, which you will perhaps also get in the chat. But this webinar was totally devoted to GLI, so you always can look it back. Second thing, which is very important for this new, second thing, people mostly say a second thing, which is very important, is the bronchodilator response. Formerly, we used 12% increase, and 200 ml is reversible or is a positive bronchodilator response. And mostly it was based on 4 doses of a beta-2, like salbutamol. With the new interpretation, we say, no, this is not correct. But because if I go from 1 to 1.2 liters, it's a very small, and it should be 4 liters, the FEV1. By the left side, it's 200 mL and 20% increases of FEV1. But it's a small variation on the baseline, which is very low. If you say we do the reversibility as we do it nowadays with 10% of predicted, you get a way better outcomes to see if you have a bronchodilator response, yes or no. And as you also can see that the amount and how you do the beta-2 is not yet prescribed, because there's still a lot of debate and discussion what should be given to the patients to get the bronchodilator response. Are you with 400 micrograms on the top of a dose response curve for each patient? How long should we wait for the post measurements? This is still not a golden standard. So what people sometimes do mix up is reversibility with bronchodilator response. Reversibility is only correctly mentioned if after your beta-2, your FEV1 over FVC became normal. So you can have quite an increase of FEV1 over FVC, but if still after the beta-2 the value is not normal, you do have a positive bronchodilator response, but you don't have a reversibility, or some people do say, well, that's a partial reversibility. It's of course what's in the name, but in this paper it's very clear. Reversibility states it's only really reversibility or a full reversibility if after your beta-2 your FEV1 over FVC becomes normal. And also in this document, you can see new examples of flow volume curves, and I think most of you are very familiar with this flow volume curves, starting with A, which is normal, and then we go to obstructive patterns, we go to fixed upper airway patterns at fixed flow limitations, and therefore fixed obstructions in the upper airways. Then you get what you can see in number E. Number F is quite remarkable. It's normally that one of the main stem bronchus is still functional, the other is not. So one lung can very fast fill during inspiration, but the other one takes a long time to fill, and then you can get this kind of very strange curves that you seldom see. Do see it. Restrictive is also something which people well do know. But this one here marked the horizontal scale 1 to 2 and not 1 to 4, which is normal. This and still also this concave pattern. This is a mixed disorder as well, obstruction as restriction. If you want to have more details, I would say read the document, and then you can find much more details. So what is also in the document are tables which help you as a clinician to see, well, if I do have something, an FEV1 which is normal or a bit lower, an FVC which is normal, and an FEV1 over FVC which is lower, what kind of things should I think of? And then you can see what you can have as choices. But this can also, of course, be done with a decision tree. And this decision tree is, there are 3 of these decision trees in this document. And then you simply can first start, of course, with the FEV1 over FVC and see if it's normal or not. And then you go to the left or the right, and we will see that in the next slide as an example. Here you see a nicely built up slide in which you have spirometry outcomes, and here you see I hope you can see my cursor because I'm moving the cursor. Yep, I get a confirmation. Then you can see in the first column, well, of course, you can see what quantity we are looking for. Then you can see what the value was before medication, what is the lower limit is normal. You can see the Z-score before medication. You can also still see the percentage of predicted based on the GLI values, as you can see in the last column. Only, for instance, for the peak expiratory flow, we don't see a GLI value, but in the enhance, which is most common in the USA. But if you are in Europe, mostly the ECCS is still based off Flip-Kanye is used. Simply because in the GLI values, we don't have normal values for peak expiratory flows, because although it was based on almost more than 50,000 healthy adults, the variability in the peak expiratory flow was that high that Flip-Kanye, who passed away but was a personal friend of me, we discussed a lot, he refused to put normal values for the peak expiratory flow in. So sometimes, therefore, parameters which are not in the GLI because there was not consensus about the data, there was too much variability, you will still see that you have other reference values. And then what you can see at the left, okay, we first have to see what is the FEV1 over the FVC. Well, as you can see in this nice animation, which Nadia made for me, you can see that in this case, the Z-score is in the range between minus 1.6 and plus 1.6, so it's in a normal range. So is the FEV1 above or below the fifth percentile? Yeah, it's above the fifth percentile. So that what we then do is we go to the FVC and we study the FVC. Well, the forced vital capacity in this case is also normal. So what we end up is going from the FEV1 over FVC is normal, the FVC is normal, so we end up in the case of a normal spirometry. And here, as an add-on help, which you can still see, you can see if we are ending up not normal, how much the impairment is. You can also very nicely see it graphically in this colored part at the left side. As long as you're in the green area, and you see for these parameters, too high isn't wrong. You only see a yellow, red, orange, red part at the left. If you're at the left of this minus 1.6 black line, then some or more of these parameters might be impaired. And later on in the second half of this talk, Nadia will show some examples in which we have more clinical cases in which we do have impairments. But here we also already have one in here. As you can see, in this case, there are numbers in red. The FEV1 is too low, but the FEV1 over FVC is also too low. You can see it very in one glance at this graph. So in this case, the FEV1 over the FVC is not above the fifth percentile. So we go to the right. And what we then do see, so this is indeed 3 Z-scores, 3 standard deviations too low. The Z-score is minus 3.2 almost. Then we go to look for the FVC. What is the FVC? Well, the FVC, as you can see, is almost 0. So it's perfectly, as you also can see here, normal. So the the FVC is normal. And what we end up is we go for the airflow obstruction. We end up with an airflow obstruction. And here you can see the clarification. FEV1 is below the fifth percentile, so below the lower limit of normal. FVC is normal, but sometimes then lung volumes are still very necessary to see if you have hyperinflation, because if there is an obstruction, your residual volume might be too high, FRC might be too high, your total lung capacity might be too high. If you want to know that, then you need static lung volumes. But in this case, if we use again the Z-scores to classify, then we see that the Z-score of the FEV1 over the FEV1 is minus 2.2, and we are in the case of for the FEV1 mild, and if you go for the FEV1 over FVC, we see it's minus 3, and that's a moderate obstruction. Okay, static lung volumes, that's the second table, the second flow chart in the document. And you can see it becomes already more complicated because for the static lung volumes, a TLC can be too low. And then we directly do think it could be a restriction, or the TLC can become too high. And then we do think air trapping, hyperinflation. So you have much more possibilities with parameters like the TLC, like the functional residual capacity, like the RV, and also if you divide them on each other, are too low, too high, or normal. And again, for clinicians, it's very helpful that if you have this kind of parameters, you can see here a clarification in this table at the right side, which kind of disease or impairments you can think of. So is it something like, for instance, muscle weakness, or is it a mixed disorder? Or is it a complex restriction? In the next decision tree, we will see, let's say, the structured way how we can do the interpretation of this table. And here you can see, therefore, this decision tree has become larger because a TLC can be too low, but it also can be too high. So if it's too low and too high, you can see you can end up somewhere here or here or here. And compared with the 2005 documents, you can see we have more outcome measures now, varying from a simple restriction, a complex restriction, a mixed disorder, normal, hyperinflation, larynx, or hyperinflation. And we again have an example to hope to make this more clear to you. And in this example, you can see, so based on static lung volumes, and it can be measured in a body box, or it can be measured with the nitrogen washout, as you can see on in the next example. Here in the plethysmography, we again start to see what is the TLC. Well, the TLC in this case has a normal Z-score close to 0, within the -1.6 and the +1.6. So the TLC is below the 5th percentile? No, we go to the left. Then we do see, is the TLC above the 95 percentile? Is it too high? No, we are in the correct range. As you can see here, also directly graphically, it's in the perfect place, almost close to 0. So it's also not too high. And then you can go for FRC as a fraction of TLC and the RV as fraction of TLC. But as you can see, although FRC is nearing the black boundary, and here you can see it's -1.5, so almost -1.6. So FRC might be a bit low, but still within the normal range. As you can see, then we end up in fact with normal lungs. Sorry, a bit too fast. We end up with normal lungs. And of course, in this example, I didn't give you, for instance, the BMI of the patient, because this could be a man, for instance, with overweight, having a high BMI, and therefore breathing on a low lung volume, a lower FSC, close to the boundary of being abnormal. And here we have another example of a patient with a nitrogen washout way, also a way which nowadays replaces the helium washout system, since helium becomes scarce and expensive. And with the nitrogen washout, you go to the same tree. You start with the TLC and see, okay, in this case, the TLC is almost -1.6, so it's a bit nearing to a low value. Then is it too high? No. Then we can look on the FSC as fraction of the TLC and the RV as fraction of the TLC. And you can see in this case, in this example, both are lower than -1.6. So they are outside the border of normal. And you can also see that very nicely graphically directly here that the blue dots are at the left side and in the orange-yellow area. So in this case, this part here isn't normal. And we might say that although we have a normal total lung capacity, we have something which might be questionable due to the low FRC as percentage of TLC and the low RV as percentage of TLC. Last but not least, we have the CO diffusion. And the CO diffusion, again, such a decision tree. And again, the DLCO can be too high or too low. For instance, if you have a lung bleeding, you have too much blood in your lungs, and you can get values of your DLCO which are too high. And again, we have a nice decision tree for this as well. Again, an example here in which in the first example, you can see all the blue dots are in the normal range. So we end up with a DLCO, which in this case was yet unadjusted for instance, for the hemoglobin, which is normal. And we end up that in this case it is normal. But be aware that if you have something which is unadjusted, it can be a huge difference if the hemoglobin is disturbed. Each year we have in my lab, I would say a lot of patients, well, a lot, at least 10 patients who come up with a lot of dyspnea complaints. And the only thing which you do have is total normal lung function, total normal lung volumes, but their DLCO is very much impaired because they have not enough hemoglobin. They have an anemia which causes them to have these dyspnea complaints. So be always aware that if you use CO diffusion, we always do the finger prick and measure the hemoglobin. We adjust for that. Again, here you can see an example, and nowadays it's a nice rapid real-time analysis of the CO diffusion. You can see if your measurement is based on the right part of your measurements, and you can see where you do end up. So in this case, since the DLCO is less than 1.6, we have a mildly reduced but a normal VA. And in this case, we end up in this case with something which might be a pulmonary vascular abnormality, but also emphysema or anemia, as stated. So therefore, it's also here marked with a mark. Do always think about the hemoglobin. Because if I can adjust if I have a hemoglobin sample, then I can see if the real problem is that the person has a low amount of hemoglobin, or if there's really an impairment, for instance, based on the membrane. So my almost last slide is summarizing up and stating that with this new decision trees, we have a standardized way how you can do the interpretation of your outcome. We always would advise you as ERS ATS to base them on the GLI equations, reference values, and also these reference values are freely available. Do not use fixed percentages as being 80% is normal and 70% of lower is wrong. Preferably work with set scores. If you're still a bit unused to that, just compare if your parameter is lower than the lower limit of normal, or if sometimes it could be higher, if it's higher than the upper limit of normal. And that's sometimes how I still do reports to, for instance, my cardiology clinicians who do not still all work with Z-scores, stating, well, I have lung function in which everyone is lower than the lower limit of normal, therefore it might be something which is an obstruction. Of course, first starting with the FEV1 over FVC. And the big change for the reversibility, well, I should not have mentioned its reversibility. I should say the bronchodilator response, of course. The bronchodilator response, the old one was based on if the FEV1 and the FVC increase 12% from baseline and is more than 200 ml as at least. The new one says no, FEV1 or FVC should be increased more than 10% as predicted values. And that changes a bit that if you have very low lung function from, as an example, 1 to 1.2, formerly this would be based as a patient with, for instance, severe COPD with an asthmatic component. Nowadays, we see that it's better defined as somebody with having not a bronchodilator response. I think was my next slide. We now go in the real practice. So Nadia, you can take it over from here with the real patient examples and also show us how it works in Centric.
Thank you, Frans, so much for that very thorough review. Just give me a moment while I share my screen. Hopefully everybody can see that.
Yep.
I think, you know, for sure, I probably speak for the group. I know at least for myself, when I first saw those new standards, that it is a lot to consider or think about. But I hope that from what Frans just stepped us through, you feel that it is worth it. This more comprehensive approach, it offers this greater level of precision when it comes to describing the lung physiology, in particular when there's an impairment. You saw that in the lung volume decision tree. Once you stepped into that restrictive lung function impairment, you have 3 classifications. That type of classifying, it allows appropriately splitting of, you know, diseases or impairments, and which potentially allows clinicians, physicians to apply a targeted therapy. So for those of you guys on the call who don't know me, I'm Nadia Stachowicz. I'm a senior product manager of PFT for Vyaire Medical. Prior to my 11 years doing this, I was in an academic university hospital setting as an RRT for around 11 years. I loved the PFT lab. I feel like my heart is still there. I would like to take what Frans just walked us through. And, you know, of course, as a clinician, we don't often get the luxury of seeing everything really chunked out like that. So I want to look at it through the lens, the practical lens of our day-to-day interpretation of data. How can we make the transition? How do we make the transition from the 2005 interp standards to the new standards, these current standards? And I'd like to demonstrate how a tool like ArtiQ.PFT that provides complete synchronicity to those new standards might alleviate some of the learning curve, or at the very least support our clinicians as they get comfortable with those standards. But of course, at the same time, you want to ensure that your PFT lab is staying accurate and boosting the consistency and the standardization of your interpretations throughout your lab, whether that's, you know, locally in one place or if you have many labs connected. So before we jump into the software to show you some case studies, I have to answer, what is ArtiQ.PFT? It's a secure cloud-based software solution that essentially takes some of the parameters, takes the parameters of those routine pulmonary function tests that we do and looks through those patterns, looks through those decision trees, like I said, completely synchronized and harmonized to those standards that Frans just stepped us through. And then it looks to say, is this normal or impaired? And how can it classify that pattern? All according to those standards. And then you as the clinician and or physician are gonna have a statement that you would look at, review the data and take it from there. For those of us on the webinar, I've been in PFT, I kind of outed myself for 20 plus years. The desire for automated computerized support with stuff like this, lung impairment interpretation, so to speak, it's been around since 1975. So for many of us, this is not a new idea or new concept. Let me just switch my screen here and go into the software measurement. Hopefully you guys see a work list of patients in front of you. Can you confirm that for me, Frans?
Yeah, we can see your sensor sheets. Looks fine.
Awesome, thank you. So what you see in before you is essentially a work list of what a physician might see when it's time for them to sit down and, you know, review the data and provide an impression. I'm just selecting batch mode. All that does is it allows the subsequent test to unfold as soon as I'm moving through the prior test. So what I want to do first is demonstrating that tool. So over here is this tool we're speaking about. It tells you that if you select this, this is a characterization that's based on those latest standards. So I'm going to go ahead and click that. It comes back to us and it says the spirometry suggests a restricted pattern and measurements of lung volumes are missing. I know that they aren't there because I can see that and I don't see lung volume data, so that's correct. it suggests the PRISM, the preserved ratio impaired spirometry. So for some of you, probably many of you on the webinar are familiar with PRISM. That's essentially an abnormally non-obstructed looking spirometry pattern. So if we're looking at this the way Frans just stepped us through it, you have obviously this really nice graphical representation, but you're looking at that chart and you're going directly to that Z-score, and it is not below that 5th percentile. Then you're coming to these Z-scores, and that is below the 5th percentile. So that is that abnormally non-obstructed spirometry or preserved ratio impaired spirometry. It applies the new BDR standards of 10% change that Frans reviewed with us. And then it goes further to say, hey, there is such an increase from that inhaler that this could be indicative for asthma. So as a clinician, I can start thinking about this patient's history and physical. What do I want to do next? Do I want to consider imaging? Do I want to consider something, an inhaler? Right? As the clinician, the physician, I get to be that clinical person. As long as I agree with the interpretation, I simply click sign and we move on to the next interpretation. So this is a methacholine or a bronchial challenge. I have a PD20 of 20 micrograms. I'm going to go ahead and click this PFT data characterization provided by ArtiQ. It's going to come back and say this is moderate airway hyperresponsiveness. And of course, we see that on this report, there's this right out of the guidelines that tells us, yep, 6 to 20 microgram response is moderate AHR. And again, that allows me as the clinician to decide what to do next. I'm going to just sign that and move on. Here we have this full study, spirometry, lung volumes, and diffusion. So we'll just come over here. I will select my icon. And now I'm going to decide as, you know, the clinician, the reviewing clinician, do I agree with this? Normal lung function, normal lung volumes. Well, again, we have a really nice graphic, which is essentially that bell curve, except in bars. I'm going to look at that Z-score, looks great. I'm going to look at these two Z-scores, also looks great. If you are, you know, if there's something that you comment on, say an FEV3 over FEV6, you can, of course, use your templates and your library of statements that you have currently. You would just simply click that on. And if I like everything, again, you're just going to sign and send. So again, hopefully supporting our clinicians as they're getting used to that new, more sophisticated approach to doing this, that more comprehensive way of looking at the lung function measurements. Looks like here we have a pre and a post again. Here, what we're coming back with is normal spirometry, but in fact, the spirometry was repeated lying down. So when we look closer, we do see this is a seated and supine, right? We know as clinicians, we often do that when we're thinking about diaphragmatic issues. So going through, looking for those patterns, looking through those decision trees, we come back with there's a reduction in FVC or FEV1 greater or equal to 20%, which there is, when lying down, which is indicative for a diaphragmatic palsy. So I will sign that and move on to the next interpretation. And on this one, again, you could really use this tool in whatever way you like. You could just scroll and look first, or if you're learning, you could have those guidelines in your sys tray of your computer or next to you in a document, and then go through it that way. So really just supporting you to move through this. Simple restrictive lung function, mild restriction with normal diffusion. So I think what's interesting about this case, and Frans, you mentioned it on your slide, and you talked about folks with the shortness of breath and the anemia. You might be, you know, when you think about that decision tree Frans shared from the standards, if you only looked at the unadjusted diffusion and you thought about that Z-score, you could be tempted to think, wow, well, I know between 1.65 and 2.5 is mild, so 2.5 to 4 is moderate reduction. But in fact, this person's hemoglobin is 8.3. So when we do the predicted correction for that hemoglobin, we actually see that they are normal. So, you know, that's actually one of those things to consider when looking at this. Do I need to grab a hemoglobin on this person? And of course, you You also see it here again in that really nice graphic representation. And I think we probably have time. Oh, we probably have time to do 2 more of these. Let's see if I select my icon. I have simple restrictive lung function with a moderate restriction, normal airways resistance. Again, remember, this is not, it is classifying and following the patterns. Moderate reduction of diffusion, low diffusion in VA with a low or normal KCO is consistent with loss of AC structure. This is a pattern of ILD. So if we are looking at this, we can look at the Z scores here, which look great, but then we do have some below 5th percentile, quite below on the FEC and FEV1. So it looks like this is coming back with what is appropriate for this test. And what I can do again is, as long as I agree, I sign it. If there's something else I want to add, of course, I can do that and move on. And sorry for the, I just wanted to make sure I was quick about it, but obviously you could put in whatever impression you prefer at that point. We finished our, classification of that work list. And I hope that in doing that, you are able to see that with a more comprehensive approach, we can be a bit more granular. And we're also trying to just support those clinicians so that you're able to sit and think about, well, what do I want to do next based on what I'm seeing here? Rather than having to move through all those decision trees, especially when something is new. So with that, I think we have about 15 minutes for some Q&A. Have not had a chance to look at the Q&A yet. So
Nadia, thanks. I saw the Q&As coming in. So, and there are several Q&As which I think you can answer perfectly. And the first Q&A question is the VMAX center seat software now calculating the new bronchodilator response based on this new guidelines? So does it now use 10% of predicted change, or does it still use 12% and more than 200 mL? What does the VMAX center seat software do?
Sorry, Frans,
Okay.
On the VMAX software, say that again.
Yeah, the center suite, the question is, does now the center suite software already calculate bronchodilator response by this new 2010, or does it still use 2005?
So it's really just a switch within the software. There's a radio, and of course that's a question that is a little bit tricky to answer because I'm not sure what version, but it should be there. It's a simple switch of a radio button to tell the program to calculate according to the predicted for the comparison rather than the older way of doing it.
Yeah, I can say we already made the switch, and so we do have the center suite, and we have indeed it's based on a new.
Yeah, I will say we have some. I'm not sure who asked the question, and that's okay. We don't need to know, but I will say we do have a few labs that what they're doing currently is to get kind of used to this new BDR calculation. They're keeping both columns on the report of the old way and then also the new way. When the numbers are small, what I've noticed is it's not really that different, but when there is a much larger change, it's this new way of calculating the BDR, you will see a much greater % change.
Yeah. And the second question, or the next question, I think this could be a question to both of us. Are there any examples on using this on pediatric patients? Well, if I start with the answer myself, it's indeed the GLI is based from 3 to 95 years for the spirometry. So indeed, for those you can very well use it for pediatric patients. But for instance, the BDR, the bronchodilator response, also in this thick document states this 10% is the best value for adults. For children, it's still a discussion if you should use 10% or even go down to 8.3 or 8.4%. So do always think, but which Nadia also states, that if your value is 9% or 10% or 11%, if it's close to such a boundary value, do always take let's say what the patient states, that he or she becomes short of breath when there is let's say spring in the air, and that if he takes the puff, he feels or she feels much better. This is sometimes, let's say, much clinical useful information is taken. No, you still have only a bronchodilator response of 9%. So we don't say it's positive. Always also take the clinical case into account. But yes, and of course, for the static lung volumes and the CO diffusion, if you don't have normal values because there were not enough children in the database, then it becomes hard to use this kind of trees for pediatric patients. This would be my answer to the question. Do you have additions to this answer?
No, I would echo the same is about that using this in pediatric patients. That since GLI is from 3 to 95 for Spiro and I think 5 to 80 for diffusion, those are essentially your quote unquote cut points, if you will. I think, you know, that's, as Frans mentioned in the first couple slides, is the goal of that new standard is really to say, let's stay with these global lung initiative, these reference values that really cover from, you know, almost birth through age. You know, if it's in that age bracket, then of course, then you could use it. And from the ArtiQ standpoint, if that's specifically what you're asking about, that's going to follow whatever the GLI and whatever the consensus statement of 2022 is. When I say it is synchronized to those standards, it really is synchronized to those standards. Frans, I see one here that I think would be a great one to have you answer. Is DLCO interp in the presence of a low VA?
Yeah, I would, if you will answer this question, in fact, the best would be to go back to the slide in which you go to the scheme, and then you can see that you still at that moment cannot give the correct answer, because you also then need to know what KCO is. And well, I can of course have it fast like this way. You can see DLCO, you can see VA, and then it's yeah, I think
I'm going to pull it up for you. There we go.
Yeah, here we can see it, the answer on this screen, as you can see. So the DLCO is lower than the lower limit of normal. Then we have the VA, and the VA in this question is also low. Then you see that you still need to know what is the KCO. Is it low, normal, or on the high side? And if so, then you can see that on the one hand, it could be a loss of alveolar capillary structure. There's examples like emphysema or an interstitial lung disease. But if the KCO is high, you can see that there might be other cases. So you can see that this decision tree very nicely can answer such a question.
There's another question here that I really like. It says, with the new guidelines, do you grade the restriction severity based on the Z-score of the TLC or based on Z-score for the FEV1? Old guidelines was based on FEV1. I think that's definitely, let me go back to that, that decision tree here. Frans, you are more than welcome to answer this one, but for sure you're grading this, I would guess, on the TLC.
Yeah, of course, it is the TLC. What formerly was that in the old guidelines, of course, not everybody has a body box, and therefore doesn't have static lung films and doesn't go not go to this decision tree. But if you especially had a low vital capacity and FEV1 over FVC, which was normal or perhaps even a bit higher than normal, then you had a high chance that it could be a restriction, because there was not an obstruction. So air can go out fast if you have a restriction. So your FEV1 over FVC can even be normal to high. And if your VC is low, Then you had, let's say, a way to think this could have a high chance of being a restriction. But if you really want to know if it is a restriction, you have to have the static lung volumes. What people do, and you can also read it in the paper, is in that case also go for a slow vital capacity, see if it's much different than the forced vital capacity, because you prevent airway collapse if you do a slow vital capacity. Or even do an inspiratory capacity measurement, go very slow to the residual volume, then do an inspiratory vital capacity. Then you have a huge negative interpleural pressure. It opens up all your lung tubes, and in this case, you get normally the highest vital capacity. But our guidelines are based nowadays on the FVC, not in the inspiratory vital capacity. So if you then want to be sure, go for the static lung volumes.
Yeah, I would echo the same. This is a question that comes up quite a bit. So I'd love to hear what you do, what you guys do in your lab and in the Netherlands. Can we use a previous hemoglobin for the corrected value? And if so, how old can those results be? In my lab, we always went back about 2 to 3 weeks. We didn't go any more than that. I don't know if you have a cutoff, if it has to be the same day. How do you deal with that, Frans?
Now, we normally do always the same day, but we have a small handheld and it's a small finger prick at the side. Indeed, you can go up to several days if you have a disease which does not influence your hemoglobin. But some of these diseases, or the patient gets packet cells or whatever, so if you have the suspicion that hemoglobin could have been changed after the last measurement of it, you should do the measurement again. And the same we, for instance, do for the air geometry. If you go for a CO diffusion, what CO diffusion can you do then? Well, we can go even up back to 3 months, because CO diffusion, if you don't have a disease which influences your CO diffusion, you might still use that CO diffusion for the decision tree of your air geometry. But that would be a total different webinar.
Yeah. Yeah, it's a great question, and I know it comes up a lot on any webinars that I've been on, and even in my own lab, we used to struggle, especially when you're seeing people who are on chemotherapies. You know, you're always thinking, how far back should I go with one of these?
We always then in these cases do it at the same day of the measurement. But as stated with the HemaQ, very small handheld, same finger prick at the side. Patients are, I would dare to say, almost used to it, so they don't have normally any. They say no, I don't want to have it. It's something totally different if you do a vena puncture or an arterial puncture. This one at the side of your fingertip really is almost nothing.
Yeah, it's like nothing. I like this question as well. And this one, I think we might have a few minutes left, but when the spirometry graph is suggestive of obstruction, but the numbers are above the LLN or above that 5th percentile, do you comment on the graph or do you read it as normal?
Okay, this is a good question, which is also partly discussed in the document. The document is a huge document. And this is, for instance, a very nice example that in some cases, an FEV1 over FVC might be lower than the lower limit of normal. But the FVC is this large that the FEV1 is still more than 100% of predicted. And formerly, in the 2005 task force, we stated this is a physiological variant. In these new guidelines, we still do say no. The person might have very big lungs, having this very large FVC, and FEV1 might be still higher than the FEV1 might be still higher than the 100% of predicted. So a positive set score. But we very then look at the details of the graph, which is a bit up the shape of the graph, the forms, which I think, but I think Nadia can go to that slide. I cannot from this side at this moment. We do look then if there is a concavity. So
yeah, you're talking about the one that has the pictures.
Yeah, all the eight forms of the volume curves in.
Yep. Sorry about if I'm making.
No problem. Yeah, I think almost there.
Here we are.
This one, yep. What you can see is that, which is, let's say, not often occurring, but a number D can occur. In number D, we can see that if you go for the FEV1 and the FVC, and only look at the blue bullet points and the Z-scores, and you don't go for an FEV1 or a peak inspiratory flow, you get a mistake that you think this person is healthy, while it's not, because the inspiration is not high enough. And that could be vocal cord dysfunction, that could be, and I even saw clinicians missing the correct decision since they didn't look at the flow volume curve. And going back to the question in detail, I always look if at the end we have something which is going, like in example A, quite good down and having a 0, or like example H, that at the end you can see that it directly goes down, straight down. You can see, okay, this patient perhaps could have blown out further. Yes, the shape of the flow volume curve is very informative. And although these decision trees are also, based for people who don't have, with handheld spirometers, don't have the nice graphs there, I always will look at the graph as well.
Yeah. I'm a big fan of the flow volume loop as well. I think we probably have time. It's 3:01. Let's do one more question. If anyone wants to stay on the line, please feel free to do so. We have a question. Do you think that having GLI spirometry, GLI lung volumes, and DLCO reference calculated on different populations may cause a lack of consistency on PFT values and interpretation? For me, what I would say, and I'm assuming this person is referencing ethnicities, you know, I think in the webinar that Nadia Stachowicz just did back in December, and I think perhaps in November, it was one that we sent through the chat, and it was on Frans's screen. She did talk about, you know, there is, and in the guideline, if we look here, does discuss this, you know, that we need to take a little more care about the impact of ethnicity. But, you know, I think if we think about the social determinants, there are so many things that impact lung function that it's kind of difficult to really know at this point. It seems like it's probably just based on the recent GLI race neutral equations that came out. It appears that it's just going to almost give you a bigger bell curve, so to speak. But Frans, what do you think about that?
No, I think you summarized it quite well. As you can indeed see in this slide on the 4th bullet point, more emphasis on incomplete understanding for race ethnicity. And as stated in this Blue Journal article, which just came out, we are working because nowadays it becomes very difficult sometimes to see what the ethnicity of a person might be. I do know an example myself in my lab about a month ago. That was a person who was a refugee coming out from Baghdad, and he had a vital capacity and a TLC, total lung capacity, which was 1 liter lower than what was the lower limit of normal. So my colleague clinician stated, do I really have to treat this person as being restrictive? And then I said, yeah, I even don't know if the GLI just give correct values in this case. So what I did do then is went back to the internet, to PubMed, find an article which has reference values for people in the big cities of Iran and Iraq. And then found out that in this case, that people had a vital capacity and a TLC, which was almost 1 liter lower than the GLI mixed or other reference values. So we still have a way to go that for certain ethnicities, the GLI isn't perfect as well. And it becomes more difficult if your father is and your mother is from another side, what is the ethnicity? And even if you pick up then the mixed, you still can make a mistake.
Yeah. The one other thing that I would add too is that, you mentioned in the beginning, and I like this analogy of the 18-year-old phone. The standard, and for any of us who've been in pulmonary function testing for a while, these standards are always evolving, just like anything in medicine should. So this is the most up-to-date thing that we have. And so we work within it, and hopefully, subjects find folks like yourself, Frans, that go and do that extra work to say, oh, I know what I'm going to do with this. I think, let's see, we could probably take one more question. Does it make sense to use carboxyhemoglobin instead of hemoglobin for heavy smokers and some professional, it just changed, some professional patients? Is it more accurate or not?
Yeah, of course. Let's say in this iodiffusion, we use carbon monoxide since it has to bind with the hemoglobin. And if there is no hemoglobin due to anemia, or the hemoglobin is already occupied by a heavy smoker, then of course you will again make a mistake if you do not correct for this. So indeed it's more correct, but sometimes it's also more difficult to get this value.
Yeah. Well, thank you, Dr. de Jongh, Dr. Frans. Thank you everyone on the webinar. We really appreciate your time. When this is available, it will be up for replay. And with that, I'd like to close the webinar and wish everyone a great day. Thank you all.
Thank you all.